Challenges to Treating the AYA CML Patient by Dr. Naveen Pemaraju, MD. The objectives of this presentation are to discuss the background of CML adolescent young adults, or AYA, to discuss some of the studies and large data sets available, and to mainly focus on the factors, barriers, and special situations preventing care for patients in this unique subgroup, including adherence. By way of background, patients with CML in the modern era of tyrosine kinase inhibitor or TKI therapy can be expected to have an overall normal life expectancy or just slightly below that of the general population. However, the current paradigm for most patients with CML still remains that they must take lifelong indefinite oral therapy for most patients on TKIs, that the continued need for ongoing access to care, cost of care, and resources, especially here in the United States, has become quite difficult with changes in insurance plans, and rising costs of care. Also, long-term side effects of the TKI therapies themselves and the issue of adherence, that is, taking this pill every day for the rest of one's life. And finally, the difficulty for younger patients as they transition from pediatric to adult care models, transitioning off of their parents' insurance and to other plans can be quite daunting. So for adolescent, young adult, or AYA patients with blood cancers, a review article in the field by Dr. Wood and Lee came out in 2011 in Blood, signifying a new change in focus for patients in this area. Although CML itself is rare among adults and even more rare in pediatric and AYA patients, estimated only perhaps 3% of all leukemia cases, the emphasis on this age range is important because as the NCI and NCCN have identified, patients ages 15 or 16 to 39 demonstrate a vulnerable, unique group of cancer patients with potentially quite unique needs. AYA CML outcomes around the world. In one large study conducted by our group here at Anderson, among 468 patients with CML, we identified 61 of those patients to be AYA, representing 13% of the CML population at that time. These patients were treated with a variety of standard TKIs with a median duration of approximately 3 years. As compared to older patients with CML, the AYA CML group had more frequent splenomegaly, and significantly more patients had low SOCAL risk group in the AYA. No other significant differences were found. Overall, AYA patients with CML appeared to demonstrate a lower response rate to initial TKI therapy, and factors that led to this may have included psychosocial factors, adherence to therapy, access to health care, and parents versus other medical insurance plans among these AYA patients. The next few slides detail other studies, including the German CML group by Calmanti et al. And the Japanese group Sakurai et al., both showing similar outcomes overall. While there may not be an overall survival worsening among AYA patients, given the overall good prognosis for most patients with CML, the less than expected outcomes among cytogenetic molecular responses and the presenting features were all notable. In terms of treatment in the AYA and pediatric populations, a recent large phase 3 trial was completed among 156 patients, ages 1.3 years to 18 years, focusing specifically on this unique subgroup. Majority of these patients were newly diagnosed chronic phase CML patients, and the treatment of choice was TKI with imatinib, the oldest and first in class. The event-free survival, or EFS rate, at 18 months was found to be 97% among the chronic phase patients, with 86% of patients achieving a complete cytogenetic response, or CCYR, by 3 years. Furthermore, 74% of patients achieved MMR, or major molecular response, by 3 years. Overall, 27% of patients were called an imatinib failure, which meant they had suboptimal lack of response to the drug or intolerance. Close to 20% of patients went on to a stem cell transplant, and the final conclusions from this large, focused phase 3 clinical trial for AYA patients with CML demonstrated that first-line TKI, in this study imatinib, is indeed effective, as was previously demonstrated for patients with AYA CML, and more patients with pediatric and AYA CML are put forward on a regular basis for stem cell transplant as compared to modern, older adult populations. Increasingly, the burden of the healthcare system itself and the financial toll of these daily oral lifelong therapies have actually increased rather than decreased or stabilized over time. For the young patient with CML, this can be quite an impossible challenge in the clinic, as they are also dealing with issues unique to this age group, such as fertility and childbearing, psychosocial aspects of having cancer in the first place, and the social isolation and lack of networking and support even in this modern digital age. A study by Dr. Pareles et al. Discussing in detail social media and internet resources for patients, AYA patients with cancer, is of great importance. And finally, the issue of adherence itself, formerly known as compliance, now known as adherence, the relationship and partnership between the patient and doctor to be able to go for a cancer treatment plan. It has been shown by Marin et al. That adherence at all ages is actually one of the most critical factors in attaining molecular response in the treatment of CML. Furthermore, Ibrahim et al. Showed that lack of adherence is one of the foremost reasons for the loss of cytogenetic response. And finally, electronic monitoring, pioneered by Eliason, Marin et al., has shown suggestions of increased adherence for patient care. The final study is the Take It study, led by Leader et al. In CML 2018, which in this pilot experience, 58 patients with CML of all ages demonstrated that electronic monitoring can be feasible and actually increase the odds of taking a TKI daily 58% greater chances after receiving an intervention from a specialized team which trained both the healthcare workers and offered behavioral change techniques to patients with CML. And in summary, the adolescent young adult or AYA cancer population represents a distinct, vulnerable group of patients with cancer who may have unique needs and concerns outside either their pediatric counterparts or their older adult counterparts. Furthermore, the AYA patient population with CML specifically represents an understudied subpopulation of patients, as the median age patients with CML is generally closer to 68 or 70 years. And these patients have experienced worse than expected outcomes in most published studies due to many factors, both host-related, treatment, and pathobiology-related factors. Investigation of these factors, including specifically adherence and access to care, problems for patients of all ages with CML, but in particular for the AYA population, are needed. Given the fact that these treatments are oral, expensive, daily, indefinite, lifelong therapy for most of our patients. And finally, future areas of research for the CML-AYA population will involve more detailed investigations of the reasons and causes for adherence-related issues, financial toxicity, and a more patient-centered approach and methodology for how to improve adherence, including possibly electronic monitoring and other modalities that have been tested in prior studies. This ends the presentation.